Welcome back to another episode of Reading Rehab. I am Mike Brown, joined by
Brian Gardner.
And Pat Healy.
And we're doing another knee article. I feel like we've been doing a lot of knees recently, but this one is a post-operative rehabilitation and return to sport following multi-ligament knee reconstruction by Munson et al. And one of the authors is Robert Laprade. I hope I pronounced his name right, who is one of the authors of the meniscus paper that we talked about like 2 episodes ago.
Mm-hmm.
This came out in 2022. What are your guys' initial thoughts on it?
I was the one that proposed this one because of a recent patient that I had come through the door who has a multi-ligament knee injury. And for people who don't know, that just means a tear of 2 or more of the major knee ligaments. So ACL, PCL, MCL, LCL, or FCL. And I just wanted to read up a little bit more about it because I feel like, when you're going through PT school, you hear about like the unlucky triad for ACL injuries, which is that meniscus, MCL, and ACL. And like that's usually, at least in my experience, like the extent of like, oh, here's like the worst this can get, but then come to find out it can actually get much worse. And I feel like that's kind of where the multi-ligament knee injuries lie. And so just to get like a read up on like, how does this look for a surgical process, for a rehab process, and a return to sport? And yeah, I feel like this article did a pretty good job at summarizing like considerations you should have. As you said off air, Mike, when we like, it's not going to be all extensive. Like you still kind of have to fish your own information out, which if you look up Jill Munson, she has another article that goes like really in depth on the surgical procedures and like the actual functionality of all these different ligaments within all different joint angles that you should probably consider throughout the rehab process. So I think that one would be more in depth for something that how we were discussing, like this article might not do as much, but I still think this one is pretty good to like make sure you're just keeping your radar up for different factors along the rehab process if you come across someone who is labeled as a multi-ligament knee injury.
Yeah, I like one point they say, because like, I mean, we don't see multi-ligament knee injuries very often, like we as in like, I feel like PTs in general don't. Me especially, like I don't know how many runners are getting multi-ligament knee injuries. But they said the recent reports are 0.072 events per 100 patient years. But then they say within the general population, I want to know how frequently these happen in sports, because I don't like, they talk about like motor vehicle accidents or like a fall from a height being like the 2 biggest reasons for multi-ligament knee injuries, when like then they say like skiing and ball sports have a pretty high rate of these. Yeah, just an interesting consideration with that. So that goes into like thinking about the goals of the patient. If it was like from a motor vehicle accident, that the late stage process looks different than if it was from like a tackle in football or something, as an example.
Yeah, to go off of that, Mike, and like you had said, not often seen in like the PT realm. Just with my experience as an athletic trainer, like you just have the more contact hours during like sports like rugby and football and those types of contact sports that you see more often. In my career so far, I think I've had probably like 5. And they were all contact injuries. None of them were like a non-contact. Like they had said, a lot of velocity. I mean, it brings me back to thinking this is going to date my age, but like the Willis McGahee National Championship, the fact that it is tomorrow, where his knee got blown out in the National Championship. They do go to say how this kind of the return to sport for this sort of injury is kind of inconclusive. I think that's just because there's not that many. But I also think that it is possible he was able to play in the NFL for a few years after experiencing that. But then you have like the other case scenario, again, going to further date myself. There was a South Carolina football player named Marcus Lattimore that had 2 knee dislocations. Yeah, so not necessarily the greatest story. But again, I don't think he ever made it after playing college football. He was supposed to be like one of the top backs when he was playing. So, but yeah, going to this, like, I mean, a lot of this is just going to be dependent on what their limitations are. I do like the fact that they make sure that they note like any disruption to popliteal artery and or the common perineal is like you need to do something quick. Otherwise, you're pretty much non-existent when it comes to returning to sport. So I think that's an important thing to take in consideration, especially if you do cover like field side, or like if you're acting as someone that's providing care on the field, because that's a little bit more of a let's get this ball rolling before things get worse. So yeah, that's kind of my personal experience with it. But yeah, I mean, these are never fun initially, but there's a lot of stuff that you just need to take consideration on the return to play.
For sure. So what does rehab actually look like? They split this up into a couple different phases, and I feel like some of their phases are kind of like weird. But the early phase, phase 1, their recovery, 0 to 8 weeks post-op. They state a couple different like goals for that, like limb protection, symptom management, protected range of motion, getting the quadriceps firing. I like they have the idea of like return to a general wellness baseline. So like through sleep, mood, energy, nutrition, that sort of stuff, and monitoring for complications. That seems like pretty standard after any sort of injury like this or any surgery. They also have non-weight bearing for 6 weeks and a knee immobilizer, which again seems pretty standard. They couple other things like you want to limit flexion to 90 degrees for the first 2 weeks, starting with passive flexion. If they injured the PCL and the FCL or the posterior lateral corner, don't go into hyperextension because that can just put extra stress on those areas. Limit open chain resistance training to at this point to limit posterior and anterior tibial translation, especially if both the ACL and the PCL were messed up there. And then by the end, they have exhibit full knee extension on 110 to 120 degrees of knee flexion. Do consecutive straight leg raises without extensor leg in a good tolerance of beginning exercises. Did I miss anything in that phase? Anything else you guys think is important?
I don't think it's like important, but I think it is important, but it's not like this is going to be mind-boggling. when you were just talking about like the PCL, FCL, and posterior medial corner, I believe it was, and how you want to not push into that hyperextension, just because those structures are meant to, prevent that. And so if you have a new graft in there that is kind of meant to help, you know, not stabilize, but like restrict a ton of motion like that, and you're just cranking on it, you're just going to be stretching out the graft. So that's kind of why, they give you that time frame of like, yeah, you don't really need this is important, of course, but you don't need to go crazy on it and try to get all the hyperextension in the world in the first 2 weeks.
Yeah, they also say like you still want extension, like you want full extension, but you're not going extra for it. So
exactly.
I think, yeah, I don't want people to take that as like, oh, we don't like stretch extension at all. Like if you don't have full extension, you want to get full
Yeah.
extension.
If there's anything I've learned, if you don't have full extension, you can just forget about everything else down the line, really. It's like that is such a hypercritical mobility goal. So I guess the next transition, or I guess the next phase they have, is called the transition phase, or they put it as, quote, acclimation to load, 8 through 10 to 12 weeks. Essentially, it's just the goals are to progress to full weight bearing without an antalgic gait and prepare the joint to accept load, to tolerate for future tolerance to strength exercise progressions. So, effusion will probably still be present, but they emphasize that it should be non-reactive before you progress out of this phase. So essentially, when someone comes in, you do a sweep test. They could be maybe like trace to 1+, but then at the end of your session, they shouldn't be blown up like a balloon, essentially.
Yeah, I thought it was interesting they put this such a short sort of timeline, I guess, on this.
Same.
But,
Yeah.
I think it was kind of just thrown in there because they just didn't want to put it with the first phase because it was now weight bearing. But yeah, I think you to go back to the last thing you said, Pat, was with the trace and the effusion stuff. You also want to make sure that it's not 24 hours as well, reactive. Just so that you're continuously trying, not just after the session, because sometimes you can get through a session and it's like, okay, next patient, or the patient's leaves, and then within a couple hours, it's like my knee was as big as a melon type of thing. So I think having that sort of expectation for that individual is saying, I want you to communicate with me and let me know outside of an instant or immediate response, was there any swelling post session? Meaning 24 to 48 hours, depending upon how frequently you're seeing that person. So I think that's important because we forget that these people go off and do their own thing. But then also make sure that you don't miss out if they're like, oh yeah, by the way, I was doing this, this, and this, and now my knee's swollen. So it's not really what you're loading. It's more the fact that individual was not compliant to following like certain things.
Yeah, that's a great point, because I was about to say, kind of to what you guys were saying, how this window feels a little short here for this transition phase. And I would say, based on my observations of what I've seen with patients in our own clinic, it usually is not this short because of the fact of what you were saying, Brian, where this is usually the point to where people will probably be full weight bearing and present non-antalgic gait, but like, to them, it could just be getting back to life things. And like how you're saying, that accumulation of load sometimes doesn't add up in some people's mind. And so it's a big education point to try to talk about. Even like things such as like step count can be quite powerful for people, just because you know, some people might not equate like a few extra 100 steps in the day to however many times that knee joint is going through however much body weight per step, you know? And so I think education, obviously, through the whole plan of care is super important, but especially at this like transition phase where you're trying to essentially still quiet the knee, as they say, but progress with some of your strengthening is especially important. And especially for like those monitoring, like subjective and objective monitoring through like self-report of swelling and like step count.
Yeah, that's where it is nice to have like to be like in a team sports setting where you have a lot of touch points with people. Um or like be very, I guess in my situation, like where I don't have as frequent touch points with people, is I would make sure that they know like this is what I expect to happen. If it doesn't, email me because like then we need to change something. Um so and like email me like quickly, like that sort of thing. I also like to go to the point on like maybe they don't have an antalgic gait and like they're weight bearing and stuff like I see this is also a pretty critical period, like psychologically too, because they may think like, oh, like I'm doing like pretty good. Like I can start doing a lot more things. To both of your points of then like psychologically, they don't want to be injured anymore. Like it's already been 8 weeks of them crutching around and like having pain when they're walking. So then once they can start not having pain when they're walking, they may start to do a lot more because they're like, oh, this is great. Like I actually have some freedom. So that's something to like almost expect with these patients. Not saying that like people will always do that, but I think it makes sense that that would happen for people. Like I could see myself doing that too. It's like, oh, now I just want to like go like walk or I was gonna say walk around the mall. That's like such a like high school kid thing to do, but like go walk around the mall. Just to like say I'm like I can't like to do something I haven't been able to do in a long time.
Doing something quote unquote normal.
Yeah.
Yeah, exactly.
Yeah.
Cool. Well, going on further here, they have their middle and late phase, which is they put as rebuild and restore. And these are just kind of pretty like broad. There's not really any like metrics here, but just, you know, resolving any range of motion, starting cardio and work capacity if this is someone who has to get back to a pretty strenuous job, reestablish tolerance to joint and tissue loading, build muscle mass, and reintegrate the athlete into the sporting environment. So,
yeah, I feel like that's where table 2 is really helpful because it like kind of coincides with the timelines that they give for like what is it? They have rebuild as like 10 weeks to 6 months and restore 6 months to a year, where table 2 goes into like sport performance testing details and goals for 4 months, 7 months, and 10 plus months. So then it can give you things to like shoot for, which I think is really helpful. I think it'd be worth going through this table a little bit. I don't love some of this stuff. Like, I guess there's tests on here that maybe I wouldn't spend the time on, but I can see the reasoning for it. Like, for example, like the Y balance test. I like that they only say like the anterior portion to essentially get like, I think their thought process is like it's essentially a single leg squat, and then it's a way to put a number on like your capacity to do a single leg squat. I don't know if you guys thought the same or had a different interpretation.
I didn't even think about it. I'm gonna be real with you.
I mean, I think they had to do something where they were doing it unilaterally. And it's just an easy one to set up with tape. I mean, I know in this article they show the Y balance test as like the actual Y balance test, like the functional movement screen one. I wouldn't say I would do this all the time, but I think in this case, the fact that it's probably a joint that's not going to fare well with deep knee flexion just because of potential arthritic changes, which is what they kind of alluded to. But I would definitely do it in this case. But that's just me. That's just an anecdotal type of scenario.
Yeah, they also I like the goals they have for like quad strength too. To go in that, like knowing like at 7 months is when you would expect like an 80% LSI. Because I feel like for, I guess my understanding of like ACL research is you probably get 80% like at 6-ish months. I could definitely be wrong there. So it seems like it's just a little later than you may expect because of this.
No,
And then
yeah,
like,
I would agree with that, Mike. I feel like you're pretty right on with that one.
yeah, and then like the 75 to 80% peak torque to body weight for that 7 months and then like knowing essentially what the end goals are too, like greater than 90% LSI, greater than 90% peak torque to body weight for both quad and hamstring. Like it's just good to, even like that first day, like that baseline 4 months, you can expect where they're supposed to be. Like you expect them to be in the 65 to 70% range, maybe a little less because it's the first time you're doing it. But then you can clearly tell them like, these are what we're shooting for, and can help give them a focus too. Cause especially after 4 months, like it's easy to become disillusioned and be like, well, I'm going to be like this forever.
Yeah, I think when looking at the strength testing in particular, though, this goes back to your pre-conversation note, Mike, where there's a lot of nuances that probably were not covered in here. I think one of them is related to the strength testing in particular, where already the values that you would expect are potentially delayed just because of how precautionary this protocol or this procedure is, because of how extensive it is. But there was no mention of graft type for any of these, like what you're going to expect from a quad or and they talked about dismissing the hamstring testing for a while, based on if you have like PCL, but like they didn't talk about like how I was saying graft type in particular, where like if you have that quad tendon versus hamstring graft, like that's going to vary what you might see, because if you have a quad tendon graft, like it might take even longer than what they have put here to regain that knee extension torque. So kind of to your point, Mike, there's just a lot of nuances that I still think weren't covered in this, but it would also be quite a task to put all of that information into this one article.
Yeah, that it could potentially be a huge article
It could
if
be
they
a
went into all
literal
the
text.
nuance.
I think it could be a literal like textbook, like truthfully, if you went into all the nuances of this and like all the surgical procedures and such. But
Yeah, to go on the surgical procedures, I mean, sometimes this is going to be multiple surgeries too, which can happen. I mean, I think if I recall my current knowledge of like the Tank Dell injury, he's had 2 surgeries already, and he's only a few weeks difference. So I think it's just depending on that. I think they just are going super conservative here just because of how much damage has done to the knee, and then obviously with like the potential to return to play being very low. I think that's, again, I liked the fact that they did say they kind of make sure you set expectations like with this person based on, I think it was like level of previous activity, tolerance to rehab progression, complexity of injury and surgery. So I think in presence of nerve or vascular involvement. So I think that's something that we as therapists need to take in consideration. I don't think you want to just put their heads in the clouds and say, yeah, we're going to do this, because sometimes it's hard. It will be hard. Not saying that you won't be able to do that, but I think it's just having those realistic expectations are going to be set you up for long-term success of life more than it is just getting back to sport.
Yeah, I almost wonder, like, in your guys' opinion, you always want to meet your patient where they're at, but if a patient who has this comes up to you and they ask, am I going to be able to play, soccer again or play whatever sport again? Obviously it all depends on like what year they are and whatever else, yada, yada, yada. But, would it be better to, just say, try our best and we have goals we have to focus on now, and let's try to like hit these goals before thinking about these things that might not be for a year and a half down the road?
Yeah, I think about these setting expectations like partially for myself too, like for this exact thing is I could see a soccer player coming up to me and being like, "Am I going to play soccer again?" And my immediate reaction is going to be like, "Yes, like you can. We can get you there. Like we can do this." Um which maybe, but also like to your point, I want to make sure I recognize how challenging that process is going to be, how long it's going to take, and like what are steps we need to hit to get there.
Well, I think you just answered the question. That's how you would answer them. Just being
Yeah.
upfront with the process more than the end goal. I think it's
Yeah.
just having the process driven goals versus like the outcome driven goals, because
Yeah.
eventually that decision will have to come, because it's like, okay, I've done all these things. Now what?
Yeah.
But
And I think, oops, sorry, keep on going.
sorry. But like that comes down to they got to be able to hit all these specific goals to that point. Um, so I think that's where, again, it comes down to, like you said, just being excited to wanting to see this person through this whole thing. But sometimes, I think sometimes practitioners are like, they let their emotions get the best of them, and it's like, yeah, we're gonna do it, but you didn't pass all these tests, but we're gonna let you play anyways, because we want to see you play. And then I think that's where you're setting up for re-injury or potential performance, like reduced performance and that kind of stuff. But I think if you have like a concrete, lay it all out in front of them, be like, these are the stages, these are the things you have to get into, this is what we have to be able to do, then I think at least you have your like whole hand in front of them, so they know as well, because you don't want to have any surprises of like, no, you can't do this, sorry, you didn't show this, and they'll be like, well, I've done all these stages, why can't I do that?
Yeah. I think there's also, like, especially when it comes to a rehab this long, that there's so many confounding factors that can lend themselves to if someone actually can get back to sport, like one of them being like the level of support they have and care and such. And then like just the timing of it, like are they aging out of it, going from high school to college or whatever else, or like college and that's it. But I think to your point, Brian, if that situation is to arise, and instead of just saying yes, saying, we that is the goal if that's your goal, but right now we have larger uh steps that we must attain to before we can even start to like do things that look like that sport, like we have steps that must be attained for you to even walk, and just trying to stress the importance of like things that don't look like sport and how important those are to get back to sport.
Yeah, I to go on your point too about like the other things going on too. I think about just like the psychology of the person as well. Like, do they like truly want to get back? Because like it's going to be a lot of work, and it's a lot of work for them. So like, we can care a lot and like, do everything that we can to help get that person there. But if they don't end up like truly wanting to do that, then one, they don't have to, right? Like, you don't have to go back and play that sport again if you don't want to. And I think that's a good conversation to have like throughout this process as well, especially if they are like going through some like a down period too. That's not like saying like, oh, it's good to give up, like that sort of thing. And it's not necessarily like a giving up. It's just like it's truly understanding what you want, and then using that as a goal versus just like arbitrarily like, oh, we're getting back to sport no matter what sort of thing.
Yeah.
I feel like that was a really eloquent thought in my head, but I don't know if I got it out that way.
No, it ripped. It ripped. Don't worry, Mike. I don't have any other real profound thoughts about this article because the rest of it kind of just, I feel like, is your standard like return to sport that you might see in terms of like, keep on improving capacities and then worry about the rate at which those capacities are shown, such as like rate of force development. And then just, kind of like that. I think they mentioned the chaos continuum in this article where
They do.
yeah. So, go ahead and check that out. I know we talked about
That
it.
was episodes 33 and 34. I went back and checked
Let's
just
go.
because I hoped that would be brought up.
Nice. Yeah. And like how we said, the return to sport on this, they put as likely a year to 18 months. I my personal gut sense is telling me it might even be longer than that because even I think nowadays with ACL, we're seeing more like year plus. And if this is a ACL plus more, I just have a suspicion this could be longer than that 18 months.
Yeah, I think like we're not like obviously we haven't gone through it, and I don't think we won't go through all this stuff, but table 1 and table 2 are pretty nice. Like we went through some of table 2. But just like if you're in Pat's situation where you have someone like you're seeing someone with a multi-ligament injury for the first time and you don't like even know what you want to be looking at, or like you can't have that conversation like we were talking about with like, oh, you need to hit X thing, then this, then this, then this can be really helpful. These two tables can be really helpful to have that conversation of like, okay, at 4 months at this first testing, we should see X things. At 7 months, we should see Y things, and that sort of thing. So just to give you tools to help communicate. Yeah. Any other thoughts before we skedaddle?
Bills up 24-19 with 12 minutes left. That's all I got to say.
You're really putting us on blast for how the short timeline we have between recording and uploading. But yeah, go Bills. Anyway, this has been another episode of Reading Rehab. As always, if you enjoy what you listen to, please follow us on Instagram at Reading Rehab Pod and leave a nice review on Spotify or Apple Podcasts. We always appreciate it. Thanks.